and weight management. So let's take a look at some body weight components. So we have fat mass, which accounts for fat from all body sources, fat-free mass, which includes water, protein, and mineral components. Now you'll also hear lean body mass, which is focused on muscle, which is not technically the same as fat-free mass. So lean body mass is going to be higher in men than women. It's going to increase with exercise, and it's going to be lower in older adults. Now it is one of our major determinants of RMR, but water is our most variable component, making up 60 to 65% of the lean body mass. Now looking at body fat, the way we account for this is we have total body fat, which is essential fat plus storage fat. And so total body fat is about 10 to 25% of body weight in men and 18 to 30% of body weight in women. And this is what we find to be associated with optimal health. Now, essential fat is necessary for normal physiological functioning and is stored in small amounts in the bone marrow, heart, lung, liver, spleen, kidneys, muscles, and nervous system. It's about 3% in men and 12% in women. We then also have our storage fat, which is used as an energy reserve, primarily in the form of triglycerides and adipose tissue, and most storage fat is expendable. So here we can see a theoretical body composition model for male and female, and so we can see our total fat compartments versus muscle, bone, and the remainder. And so again, what we see is we see thicker bones and larger muscle mass, which again is why we're going to see a higher fat-free mass or lean body mass in men, as well as a different ratio of fat, again, with the major difference coming from that significant difference in the amount of essential fat. Now looking at adipose tissue composition. So adipose tissue is located primarily under the skin or subcutaneous fat in the mesentery and omentum behind the peritoneum. Now there are technically two different types of adipose tissue. So we have white adipose tissue, and this is used as a store of energy in the form of triglycerides. This also serves to cushion and protect the abdominal organs and insulate the body to preserve heat. Now what we also have is brown adipose tissue, and so this is a rapid source of energy for infants, found primarily in scapular and subscapular areas, and accounts for up to 5% of body weight. But again, this is used primarily when the infant is rapidly growing and needs a large amount of energy and is no longer available in adulthood. Now there is some research looking at how in essence we can convert white fat to brown fat, and it's called fat beiging, but that research is still very preliminary. So looking at adipocyte size and number. So adipocytes are mature fat cells that store fat equal to 80 to 95% of their volume. And so gains in body weight and adipose tissue occur by an increase in the number of cells, increase in the size of the cells, or both. So we have what's known as hyperplasia, and so this is an increase in the number of cells, and this occurs during infancy and adolescence. And so in teens and adults, increases in fat cell size are more common, but hyperplasia can occur if the fat content of the existing cell has reached capacity. So during normal growth, the greatest percentage of body fat is achieved by 6 months of age. So it's true, right, when we see the adorable little infants and they're quote-unquote squishy, right, they do have a significant proportion of body fat. In lean children, fat cell size then decreases, and this decrease, though, does not occur in obese children. And so we have what's known as adiposity rebound. And so this occurs at age 6 in lean children, especially with girls, with an increase in body fat. Now what we see is that an earlier rebound is correlated with a higher level of adiposity at 16 years of age and in adulthood, and later rebound is correlated with normal adult weight. And so in essence, right, what we see is that at 6 months of age, children become these adorable little fat roly-polies. And then, right, as they exit infancy and go into toddlerhood, right, they should start to lean out. And then at about age 6, they should actually regain some body fat in preparation for some growing. Now, the other option we said is that we can also have hypertrophy, which is an increase in cell size. And so this occurs when fat stores expand by as much as 1,000 times at any age, as long as space is available in the cell. So what happens is that fat cell size will decrease with weight loss, but the number of cells remains the same. And so a weight loss of at least 5% is required to decrease fat cell size. So what will happen is, again, is that you're going to see a decrease across all the cells by small amounts. So it takes about a 5% weight change to see all of those cells actually change in a meaningful size manner. So looking at fat storage, so most fat storage comes directly from dietary triglycerides, and excessive dietary carbohydrate and protein can be converted to fatty acids in the liver with a very inefficient process known as lipogenesis. Dietary carbohydrates, for example, require 3 times more energy to convert to adipose tissue than dietary fat. Now, what we do see, though, is that the recommendations to reduce a single macronutrient for weight loss is ineffective. What we need is a total reduction of calories. So here we can see our CDC Prevalence of Obesity for 2018. So again, they've changed the reporting system in 2011, but from 2011 to 2018, we can compare the data. So this is just showing you, though, and this is specifically focused on obesity. Again, so the issue is that overweight and obesity have both increased in this country, but obviously, right, is that obesity carries more health risk. So this is even more concerning that we see, for example, states are reporting more than 35% of adults are obese. And so we can see this happens in a specific area. So you're looking at both parts of the Midwest as well as the Southeast. And again, we think of our traditional, right, our southern fried foods, our high-fat meats and vegetables, right, high-fat meat sausage intake, etc. Now again, why are we concerned with weight? And again, is that what we're focused on is not on an appearance issue, but again, we're focused on health issues. And so to give you an example, when it comes to fat storage, one of the things we're concerned with is things like semi-volatile organic compounds. And so these accumulate in adipose tissue from exposure to toxins, chemicals, and pesticides via the environment and the gut. And when adipose tissue is mobilized or broken down during weight loss, SVOCs are released. And so this is why you'll see that we recommend that obese women should lose weight prior to becoming pregnant, because the effects of SVOCs is not yet known on the developing fetus. So again, we know that things can be stored in adipose tissue. We know they can circulate with fat loss, but we don't know how safe that is for the fetus, etc. Now, dietary triglycerides are transported to the liver by chylomicrons, and endogenous triglycerides are synthesized in the liver from free fatty acids and travel as part of VLDL particles. Now, lipoprotein lipase, remember this is an enzyme because it ends in ase, moves lipids from the blood into the adipose cell, where it's hydrolyzing triglycerides into free fatty acids and their glycerol backbone. Now, the glycerol proceeds to the liver, and free fatty acids enter the adipocytes to be re-esterified or reconfigured into triglycerides. Then triglycerides are hydrolyzed once again to fatty acids and glycerol by hormone-sensitive lipase within the adipose cell and released into circulation. So looking at the regulation of body weight, short-term regulation governs the consumption of food from meal to meal. So this includes things like hunger, appetite, and satiety. And when overfeeding or underfeeding occurs, younger individuals exhibit spontaneous hypophagia, which is they're eating less, or hyperphagia, eating more accordingly. So if you eat too much at one meal, as long as you have, right, a healthy nervous system, right, a healthy GI system, you'll then eat less later, or if you're eating too little, you'll be hungry later. So if you skip a meal, then you'll notice that kids are ravenous. Older individuals, though, do not have the same responsiveness and are more vulnerable to unexplained weight loss or gain, as they're not as sensitive to these signals. Long-term regulation is controlled by the availability of adipose stores and hormone responses. And so we have adipocytokines, which are proteins released by adipose cells into the bloodstream that signal molecules when normal body composition is disturbed, such as with weight loss. Now, younger individuals have, again, more responsiveness to this feedback than do older adults. So some of you might be familiar with the set point theory. And so we believe this explains that deliberate efforts to starve or overfeed in a non-obese adult are followed by a rapid return to the original body weight. And so what we're seeing is that a specific body weight, in essence, is preserved, and that body weight remains stable due to internal regulatory mechanisms that are genetically determined. Now looking at signals from hormones, so several hormones communicate with the hypothalamus to control intake and weight. So insulin controls the amount of glucose in the blood by moving it into the cells for energy. Leptin contributes to fullness by sensing the body's overall energy stores. Adiponectin helps the body respond better to insulin by boosting metabolism. And ghrelin is known as the hunger hormone, tells the brain when the stomach is empty, prompting hunger pains and a drop in metabolism. Now looking at hunger communication, so we do have what's known as the vagus nerve, and this allows for communication between the stomach and brain. And so the stomach does have stretch receptors that send message to the brain indicating satiety via this vagus nerve. And gastric bypass surgery reduces stomach size and triggers a drop in ghrelin levels, which reduces hunger and overall intake. Traditional dieting, though, tends to boost ghrelin levels, and we know this is a normal side effect. So dieting does actually make you hungrier. Now looking at overweight and obesity, so again, it is a complex issue related to lifestyle, environment, and genetics. And so the US has the highest prevalence of obesity among developed nations. However, increases in the prevalence of overweight and obesity have been observed worldwide. And so the World Health Organization does have what they term globesity to help describe a global epidemic of obesity. So again, this is not just a US problem. To give you an example, so 31.8% of US adults are overweight, with 39.8% being obese. Somewhere between 10 to 30% of adults in Europe are obese. 64% of adults in Canada are overweight or obese. And somewhere between 13.9 to 20% of children and adolescents in the US are obese. So again, depending on which age group. But obesity is now the most common pediatric problem in the US. Looking at the causes of overweight and obesity. So looking at heredity and nutrigenomics. So here we're looking at how genes can influence short and long-term signals that determine satiety, the number and size of fat cells, regional distribution of body fat, and resting metabolic rate. So studies of twins confirm that genes determine about 50 to 70% of predisposition to obesity. And so there are several genes that have been identified in overweight and obesity, including the OB gene, adiponectin gene, FTO gene, and the beta-3 adrenoceptor gene. So nutritional and lifestyle choices can activate, though, or deactivate these obesity triggering genes. So again, just because you have the genes doesn't mean they're expressing themselves. Something also has to trigger their expression, which is typically environment and lifestyle. Looking at inadequate physical activity, so a lack of exercise and generally sedentary lifestyle with chronic overeating can cause weight gain. Fewer people are spending time exercising, with more people spending time screen watching and driving cars. And again, our focus here looking at health with inflammation. So adipose tissue, again, is not neutral. It actually does secrete hormones, as we discussed in previous slides. And so it also secretes pro and anti-inflammatory cytokines that can affect insulin sensitivity, hyperlipidemia, and muscle protein loss. And so there's a direct relationship between obesity and inflammatory diseases such as cardiovascular disease, cancer, and type 2 diabetes. Looking at sleep, stress, and circadian rhythms. So shortened sleep alters the endocrine regulation of hunger and appetite. And so shift workers or those with exposure to bright light at night can disrupt their circadian rhythms and enhance the prevalence of obesity. During stress, cortisol is released, which stimulates insulin to be released to maintain blood glucose levels, resulting in increased appetite. We also see what's known as night eating syndrome, so a delayed circadian rhythm of meal intake as a result of genetically programmed neuroendocrine factors, including altered cortisol levels. Looking at taste, satiety, and portion sizes, so we also have what's known as sensory-specific satiety. So as foods are consumed, they become less desirable. But what we see, for example, is at a buffet, when the diner reaches satiety for one food, they continue to have many more choices, and they continue to maintain a high intake. So in essence, right, you start eating, and eventually what tasted like the most amazing meal, you go, meh. Instead, you just switch entrees, right? But you can't really do that in the home setting. Excessive portion sizes are now accepted as normal and again result in active overeating. Again, I don't even think they still sell the small paper cups at Wendy's. And again, we also see a high intake of energy-dense foods. This is your classic sodas, French fries, etc. Now looking at obesogens, so here we have chemical compounds foreign to the body that can act to disrupt normal metabolism of lipids, resulting in obesity. And so we're looking at what we call endocrine disruptors. And so these have altered lipid homeostasis and fat storage. They can change metabolic set points, disrupt energy balance, or modify the regulation of satiety and appetite to promote the accumulation of fat and obesity. For example, one of the things we're concerned about is bisphenol A and phthalates, which are found in many plastics in food packaging. Next, we can take a look at viruses and pathogens. At least 10 adipogenic pathogens have been identified, including viruses, bacteria, and gut microflora. So you now may see the term infect obesity, which may or may not contribute to the obesity epidemic. For example, the adenovirus 36 is capable of inducing adiposity in animal studies by increasing lipid accumulation and insulin sensitivity and reducing leptin secretion. Now again, just to make sure that we're all on the same page and we've been defining our terms correctly, overweight is a BMI of 25 to 29.9, and obesity, remember, is a BMI greater than 30. Now, other things that we want to take into account are waist circumference and percent body fat, as again, this will tell us the risk of other diseases, including heart failure. So a waist circumference of greater than 40 for men and greater than 35 for women increases risk. Waist circumference is also strongly correlated with insulin sensitivity in older adults. One way we can estimate percent body fat is the Durenberg equation. This uses BMI, age, and gender to help estimate body fatness as a percentage. So here we can see the equation of percent body fat is equal to 1.2 times BMI plus 0.23 times age in years minus 10.8, and then we use either a 1 for male or 0 for female, minus 5.4. Now looking at health risk and longevity, so many diseases can worsen as degree of obesity increases, including heart disease, type 2 diabetes, hypertension, stroke, gallbladder disease, infertility, sleep apnea, cancers, and osteoarthritis. Overweight and obese people also often suffer from guilt, depression, anxiety, and low self-worth at higher rates than those who are not overweight or obese. Now again, looking at medical disorders, so obesity can also have other causes. For example, Cushing's syndrome, so prolonged exposure to inappropriately high levels of cortisol. Hypothyroidism, in which the thyroid gland does not produce enough of T3 and T4. And for example, Prader-Willi syndrome, which is a rare genetic disorder with chronic feelings of hunger and insatiable appetite. So again, here we see a chart of the previously discussed medical complications, so you can see which specific systems or locations they affect. So looking at fat deposition, so we have two categories or patterns that we see. So we have gynoid obesity, which is most often seen in females and contributes to the quote-unquote pear shape, with fat being located in the lower body, including the hips, thighs, and buttocks. And android pattern obesity, which is often seen in males, contributing to what's known as the apple shape, with fat located in the central body, including the abdominal region. And this is more likely to result in impairments of blood glucose metabolism. Now, visceral obesity indicates visceral adipose tissue under the peritoneum and intra-abdominal cavity, and again, as we discussed previously, is highly correlated with insulin resistance. Increased visceral fat is a risk factor for coronary artery disease, dyslipidemia, hypertension, stroke, type 2 diabetes, and metabolic syndrome. Now, low VAT and high cardiorespiratory fitness are important targets for cardiovascular health. So we want to, again, ensure that we're not having this visceral obesity or this abdominal obesity and improve our cardiovascular health. Now we have what's known as metabolic syndrome, which is being diagnosed with 3 or more of the following. A waist circumference greater than 40 for men or 35 for women, triglycerides 150 or greater, an HDL of less than 40 in men or 50 in women, blood pressure over 135 or over 85 or higher, and a fasting glucose of 100 or higher. And the concern is, again, this is a syndrome, this is not a disease, but a collection of these symptoms then has a synergistic effect, in this case a negative one, being even worse for your health than these risk factors independently. Now looking at calorie restriction and longevity, so prolonged calorie restriction is proposed to increase lifespan, slow aging, decrease body temperature, decrease fasting insulin levels, reduce chronic disease development, and decrease the deterioration of nerves, and result in increased nerve creation. But again, when you actually look at this data, it's actually done in animals, specifically mice, and has not actually been performed in humans. Also, again, you're looking at about a 20% caloric restriction lifelong, which again is you're basically being on like a mild diet your entire life. So it also can be stress inducing, right? It's not a very pleasant experience. So looking at the management of obesity in adults, so strategies that have been proposed include energy restricted diets, lifestyle and behavioral modifications, physical activity, pharmacological treatment or medication, surgical interventions, and again, our big focus is on weight maintenance as well as the initial weight loss. So it doesn't do any good to just lose the weight and gain it back. We want to make sure that the weight loss is maintained. And again, this should be using an interdisciplinary team where we have interactions between the physician, dietitian, exercise specialist, and behavior therapist to again make sure that we're addressing these multitude of causes. Now looking at our goals of treatment, so the goal might not necessarily be to achieve an ideal body weight, as this may not be possible or even desirable. So for example, when we take a look at the elderly, they actually have improved or reduced mortality when they're overweight. Now again, this is 65 plus, but again, if we were to bring them down to their ideal body weight, that would actually lower their BMI and would not be ideal, but they could still benefit from some weight loss if they're having other secondary health causes, comorbidities, etc. So maintaining the present body weight or achieving moderate loss is sometimes best, with a 5 to 10% loss of initial body weight likely to improve blood glucose, blood pressure, and cholesterol levels, right? So if our focus is on health outcomes, seeing that significant improvement in those labs, blood pressure, etc., right, is really our goal, not necessarily physique or a magical number. So goals should be modest and realistic, especially initially, to make sure that clients remain motivated and successful. So looking at the rate and extent of weight loss. So drastic calorie reduction can result in rapid weight loss due to the starvation response. But during starvation, right, we're going to transition to using fat as our primary fuel source. But we do see adaptive thermogenesis, which is the fancy way of saying we're going to see actually a decrease in resting metabolic rate, and metabolic abnormalities including bradycardia, hypotension, dry skin and hair, fatigue, constipation, nervous system abnormalities, depression, and even death may result if the caloric restriction is too severe. So our recommendation is a steady weight loss over longer periods of time, avoiding that sharp decline in resting metabolic rate or adaptive thermogenesis. And the goal is to reduce 10% of body weight over 6 months. And so this comes out to rates of approximately 0.5 to 1 pound per week if the BMI is 27 to 35, and 1 to 2 pounds per week if the BMI is over 35. We then actually want to shift our focus to weight maintenance for the next 6 months, and then consider further weight loss. So lose weight for 6 months, maintain, and what we actually want to then see is we can actually improve that resting metabolic rate or that adaptive thermogenesis before attempting further weight loss. Now, weight loss goals should be individualized, and the focus should be on a reduction of body fat. Now, men may reduce weight faster than women, though, even if they're the same size due to a higher lean body mass and initial resting metabolic rate. And heavier individuals expend more energy and lose weight faster on the same caloric restriction than a lighter person. So what you will see is that heavier people will lose weight faster. So looking at lifestyle modification, So behavior modification is key, involving restructuring the patient's environment, their food intake, as well as their level of physical activity. And this is done through a variety of strategies, which will be discussed further in depth in the counseling class. But we'll talk about them briefly. But this is things like goal setting, stimulus control, problem solving, cognitive restructuring, self-monitoring, and relapse prevention. So looking at dietary modification, we have things like restricted energy diets. And these are just your balanced energy restricted diet that's most widely used and prescribed for weight loss. Then there's formula diets and meal replacements. So this is commercially prepared, portion-controlled foods. This is things like Fit Life Foods or, what is that? Nutrisystem, right? Where they send you the pre-made foods. There's other commercial programs, things like Weight Watchers. Extreme energy restriction or very low calorie diets. So these are two kind of different categories or subcategories, which is you have, so calories, less than 800 calories a day. And very low calorie diets, somewhere between 200 to 800 calories a day, that are high in protein. And again, so there's a little research that suggests that they have any advantage over more gradual long-term weight loss. Looking at pharmaceutical management, so appropriate pharmacotherapy can augment diet, physical activity, and behavior therapy as a treatment option for patients with a BMI over 30 or patients with a BMI over 27 that have significant risk factors or disease processes. And pharmaceutical agents can decrease appetite, reduce absorption of fat, or increase energy expenditure, but they can be very expensive. So looking at different pharmaceutical management options, we do have central nervous system agents, which include catecholaminergic drugs, which act on the brain to increase the availability of norepinephrine, and serotonergic drugs, which act by increasing serotonin levels in the brain. Now the problem is that some of these drugs do carry side effects. So for example, fenfluramine and phentermine, known as fen-phen, and dexfenfluramine were removed from the market in 1997 due to side effects. So looking at currently approved drugs, so the FDA has two drugs that are currently approved for long-term use. One is sibutramine, or Meridia. So this is the combination of catecholaminergic and serotoninergic agents, which inhibit the reuptake of serotonin and norepinephrine and acts on receptors in the hypothalamus to suppress appetite. The side effect, though, being a central nervous system stimulant because of the norepinephrine, is that it does increase heart rate and is not used in conjunction with SSRIs, MAOIs, or ephedra. The other drug is orlistat, also known as Xenical or Ally, and this inhibits the action of gastrointestinal lipase and reduces the digestion of triglycerides. And so it reduces approximately 1/3 the amount of fat absorbed from the diet, but the side effects include fecal urgency and fecal incontinence. And we do want to recommend a multivitamin that includes our fat-soluble vitamins A, D, E, and K. Now looking at other future drugs, so there is a drug known as Belviq, which is the first FDA-approved weight loss medicine that works by targeting a hunger receptor in the brain and is believed to help control portions. The precise way that Belviq, though, produces feelings of satisfaction is not fully understood, but is believed to help you lose weight by making you feel satisfied while eating less. Now looking at our bariatric surgery or surgical options, so this is an accepted form of treatment for extreme or class 3 obesity with a BMI of 40 or greater, or a BMI of 35 or greater accompanied by comorbidities. So this is, right, we're having other health effects that are so severe we need to get the weight off quickly. Before consideration for surgery, though, a patient must fail comprehensive program including calorie restriction, exercise, lifestyle modification, psychological counseling, and the patient does need to demonstrate strong family involvement or a support network. And so failure, though, in this case is defined as an inability to reduce body weight by 1/3 and body fat by 1/2, and the inability to maintain any achieved weight loss. So looking at the different types of surgical options, so there's the adjustable gastric banding, Roux-en-Y gastric bypass, the vertical banded gastroplasty, vertical sleeve gastrectomy, and biliopancreatic diversion with duodenal switch. So first we'll take a look at gastric banding, or the lap band, and so here you can see an example of how that band is placed on the stomach. So looking at the lap band, again, an inflatable silicone gastric band is laparoscopically placed in the abdominal cavity and secured around the upper part of the stomach to create a small pouch with a narrow opening at the bottom of the pouch where food can pass through to the rest of the stomach. So in essence, we put a very, very tight seatbelt around the upper portion of the stomach, narrowing the hole. So we've created this small artificial stomach, and then nutrients, right, can still go through this small hole into the rest of the stomach, into the small intestine. Now the pouch restricts total food intake to about 10 to 15 mils initially. So this is the simplest and least invasive procedure, resulting in shorter hospitalization and a faster post-op recovery. And the band can be adjusted to suit the patient's needs, and it is fully reversible. So the idea was when we first did this, we kind of thought you'd get the best of both worlds, where you'd lose the weight, could retrain the body, and then go back to normal. The problem we found is that people would try and manipulate the pouch while they had it, so you can actually then find the port and adjust it yourself. You're not supposed to, but there were some issues with this with compliance, and so this is actually kind of starting to slowly fall out of favor. Now, the benefit, though, is that this does not require folic acid, iron, or B12 supplements because you are leaving the stomach fully intact. Next, we see our Roux-en-Y gastric bypass. And so you can see here again where you have the staple line to create the small pouch. And again, we are bypassing a portion of the small intestine. So the Roux-en-Y gastric bypass. A small pouch is created at the top of the stomach with the stapling procedure, which restricts food intake to 20 to 30 mils. The jejunum is cut and the distal end is surgically connected to the pouch, thus bypassing part of the small intestine, decreasing nutrient absorption, but this can also be performed laparoscopically. Now, some of the side effects is the patient may have dumping syndrome as food empties quickly into the small intestine. And with dumping syndrome, you'll see abdominal pain, sweating, and tachycardia. And the idea is, though, is that you're kind of giving them this negative feedback, which is if you overeat or you eat the wrong foods, right, you'll have these physical consequences, and you'll kind of retrain the body to avoid doing that again. So kind of like if you've ever eaten a specific food and vomited, and you're like, I'll never eat that food again. The same way, when you eat this food, you'll have these severe symptoms and not eat those foods or that pattern again. Now, eventually the pouch can expand to accommodate 4 to 5 ounces, but supplementation is necessary, so focusing on a multivitamin and looking at calcium, iron, vitamin D, B12, and folic acid. So here we do have, again, some malabsorption. Here we can see a vertical banded gastroplasty. The vertically banded gastroplasty, also known as stomach stapling. And so the size of the stomach is reduced by stapling a portion of the stomach to create a small gastric pouch. The opening may be banded by a piece of mesh to prevent it from enlarging during the years after surgery. This surgery, though, is also losing favor as more doctors are using the Roux-en-Y gastric bypass. Here we see the vertical sleeve gastrectomy. And so with the vertical sleeve gastrectomy, up to 85% of the stomach is surgically removed, leaving a narrow tubular banana-shaped portion of the stomach between the esophagus and the duodenum, also referred to as a gastric sleeve. This restricts the stomach capacity to 50 to 150 mils while preserving its functions and leaving the pylorus or the sphincter. This is usually done laparoscopically, and supplementation is necessary. Here we can see a biliopancreatic diversion with duodenal switch. So the biliopancreatic diversion with duodenal switch is the most complicated surgery and least frequently performed, but it does result in the greatest amount of weight loss. So this is reserved for patients with a BMI over 50, and there are 2 stages of surgery. So in the first stage, the vertical sleeve gastrectomy is performed laparoscopically, and in the second stage, the distal part of the ileus is surgically attached to the stomach. Now again, similar to the other procedures, this does require supplementation. So looking at outcomes with bariatric surgery, most patients lose 30 to 35% of total body weight in 1 to 2 years, and we see successful maintenance in about 60% of patients after 10 years. Benefits include improvement in blood glucose management, sleep apnea, hypertension, and cardiovascular disease risk factors. Post-op complications, though, can include nausea and vomiting, dumping syndrome, wound infection, anastomotic leaks, and pulmonary embolism. Now, we're going to discuss a bariatric diet, and this is the post-op diet. Now, this is one example. So unfortunately, as with some other diseases, there is not a standardized post-op diet for bariatric surgeries. There are some pretty well agreed upon practices, but each individual practice or doctor will have their own specified diet. And so I have actually seen multiple post-op diets within the same hospital because the doctors, even within the same practice, don't agree on a specific procedure for advancing the diet. So this is just one example. So what you may see is for the first 1 to 6 days post-op, so post-op days 1 to 6, is sugar-free clear liquids. Again, this is to avoid dumping syndrome. Post-op days 7 to 30, so for that after the first week into the first month, 2 ounces of protein 3 times a day with water and sugar-free clear liquids. So again, you'll see a specific type of protein powders frequently used. After the first month, so going into the post-op 2nd to 4th months, they'll add in soft, well-cooked vegetables and unsweetened canned fruits. Again, this is mostly for digestion because the cooking process makes it easier to digest for the pouch. And post-op months 5 and beyond, 2 to 3 meals a day, and can experiment with adding other foods as tolerated. So looking at some commonly agreed upon bariatric diet guidelines, this is no more than 3 meals a day, no snacks unless they're sugar-free beverages or water, no supplements, no alcohol, an emphasis and focus on protein first, which should be approximately 1/2 of the meal, eating only when hungry and stopping when full, daily exercise, liquids between meals, not at meals, with at least 64 ounces of water per day, a multivitamin twice a day, and this is because of a change in digestion and absorption, with a focus on calcium and B12. And again, food should be in small amounts or sugar-free to help prevent dumping syndrome. Now looking at bariatric surgery follow-ups, so to monitor after surgery is a food recall or food records to look at sugar intake, liquids between meals, and if they are focusing on protein-dense foods. Monitoring for signs and symptoms of dumping syndrome, including nausea and vomiting, bloating, cramping, abdominal pain, and diarrhea. Monitoring for any vitamin and mineral deficiencies, the amount of weight loss, lipid profile, electrolytes with a focus on potassium, especially due to the possible diarrhea from dumping syndrome, and hydration status, again looking at total fluid intake and a possible side effect of dehydration due to the diarrhea. So to maintain this new reduced body weight, and this is not just for bariatric surgery, but conceptually all weight loss. So the National Weight Control Registry identifies behaviors reported by participants that help to maintain weight loss. And so this is eating a relatively low-fat diet, eating breakfast almost every day, weighing themselves regularly, usually once per day to once per week, and engaging in high levels, approximately 60 to 90 minutes of physical activity per day. Now, common problems in obesity treatment includes the plateau effect, where weight remains at the same level for long periods of time. And there are several theories, including metabolic adjustment, release of adipose toxins, decreased resting metabolic rate due to lean body mass, etc. To move out of this phase, it usually requires either an increasing activity level or significant decrease again in calories. But again, if we've been consistently dieting, we can only reduce calories so much, so we'd prefer to increase physical activity. Now, things to avoid, because they are common, but again, they're not desirable, is weight cycling or the yo-yo effect, which is repeated bouts of weight loss and regain. And again, this results in increased body fatness and weight within the end of each cycle. Now, looking at weight management in children, so this is a bit of a review from life cycle class. Childhood obesity increases the risk of obesity in adulthood, and the treatment goal is typically weight maintenance or to slow the rate of weight gain and to allow the height increase to even out. And weight loss, though, may be desirable if the BMI is greater than the 95th percentile with secondary complications. And looking at the possibility of bariatric surgery, this is considered if the BMI is greater than 50 with the presence of comorbidities, and the child needs to have attained skeletal maturity and gone through puberty, and must have the decision-making and emotional capabilities to understand the extent and the importance of this surgery. Now, on the flip side, looking at underweight, So this is applicable to those who are 15 to 20% or more below accepted weight standards, and this may be associated with a disease process. And so again, because of this U-shaped curve, a BMI of less than 18.5 is associated with greater risk of death. So again, that's why you can be too low of a BMI as well as too high. And risk factors include underfunction of the pituitary, thyroid, gonad, and adrenals, and also increased susceptibility to injury, infection, and an overall lack or loss of energy. So being underweight or unintentional weight loss can be caused by inadequate oral food and beverage intake with insufficient quantities to match physical activity, excessive physical activity, inadequate capacity for absorption and metabolism of foods that are consumed, a wasting disease that increases the metabolic rate and energy needs, or excess energy expenditure during psychological or emotional stress. And so the assessment of underweight individuals is a first priority is to determine the underlying cause. Consider nutrition support, dietary changes, and psychological support. Appetite enhancers or stimulants may be considered, and so there's a category of medications that actually increase appetite. And a high energy diet with the encouragement to eat. So liquid supplements may be effective. This is things like Boost, Ensure, etc., and providing somewhere between 500 to 1,000 extra calories per day. All right, so let's take a look at some practice questions. So the most variable component of energy expenditure is, and this is answer choice C, energy expended in voluntary activity. Number 2, the hunger hormone is, and this is answer choice B, ghrelin. Number 3, the best way to maintain a healthy body weight and prevent weight regain is to, and this is answer choice A, adopt healthy lifestyle habits. Number 4, the goal of intervention with an overweight child should be, and this is answer choice D, weight maintenance or a slowing of the rate of weight gain. And number 5, overweight or underweight are caused by an imbalance among, and this is answer choice A, energy intake and energy output. Thank you, and I look forward to your questions.